Good evening, everyone. I hope you can hear me. I am Nick Dukic, International Business Manager at Rayner. A warm welcome to all of you who have joined us tonight. We have a wonderful educational webinar for you this evening, an update on Rayner Premium IOLs, plus RayPRO as a contactless telehealth solution for collecting patient outcomes data. I'm delighted to say we are joined by guest speakers, Dr. Khaled Al-Arfaj, Associate Professor and Chairman of the Ophthalmology Department at the Imam Abdulrahman bin Faisal University Hospital in Amon, Saudi Arabia, who will present on how to introduce premium IOLs to your practice. Welcome, Dr. Khaled.
Welcome back, thank you.
I'm also delighted we are joined by Professor Michael Amon, Head of Ophthalmology at St. John's Teaching Hospital in Vienna, Austria, who will introduce us to Sulcoflex Trifocal, the DUET procedure, and share clinical outcomes. Welcome, Professor.
Good evening, everybody. Good evening.
And last but not least, my colleague here at Rayner, Mr. Sam Carter, International Product Specialist, who will go into more detail of our trifocal patented design, plus the importance of patient-reported outcomes and RayPRO. Good evening, Sam.
Good evening, Nick.
That's all from me. Sit back, enjoy, and I will now hand you over to Dr. Khaled. Thank you.
I'm very thankful for you, Sadiq, for your nice introduction of this interesting meeting. And I'm really very thankful for the Rayner company and their scientific team for arranging this wonderful gathering. Hope to share with you some of my experience in Premium IOLs and how to introduce the Premium IOLs in your practice. Without further delay, I will just, does it share with you now? I don't have any financial disclosure and our interest in any material and the products will be mentioned in this talk. And my objectives in the talk will be around these, answering these questions. What are the premium IOLs? Do we really need the premium IOLs in our practices? Some pros and cons of these premium IOLs and the pitfalls, how to select your cases to optimize your results, especially in your first cases. There is no doubt the cataract surgery nowadays is a refractive surgery, and the demand to have a perfect results are really needed from all the patients. They need really excellent results, perfect vision without spectacles at both distance, proximal activities, and even intermediate activities. They really need a really wide dynamic range of vision. And with the old and still used monofocal lenses, we cannot provide these patients with these important dynamic range of visions. Accommodation, we know, is gradually decreases with age, and global prevalence of presbyopia is really huge. It's reached now 2020 1.5 billion, and currently the surgical options were offered less than 1% for treating presbyopia. So this is the answer of our next objective. Do we need the premium IOLs during, for our practice or not? Even if you looked at the astigmatism prevalence, you will see that the prevalence of refractive astigmatism, more than one diopter, is present according to some studies from 15% to up to 35% globally. So there are a lot of patients with the significant astigmatism we need to tackle and let them be free of glasses post-surgery. There are a lot of thoughts before about the multifocal lenses, and we know even from the beginning, from 2000 and above, we see a lot of versions of old multifocal lenses, and many of us, it's planted, and we have really bad stories and really bad thinking about this dark side with the multifocal lenses. However, these things are really changed. This is the unsatisfied results were presented in for the old versions of multifocal lenses. Nowadays, we have the technology is different, and we will see somehow in this talk, and maybe Mr. Sam Carter will even talk about specifically about the technology of the trifocal lenses, and we'll know that there is really difference in the new versions of multifocal lenses. In 2016 European Society of Cataract Refractive Surgery, the 57% of the surgeons will target to provide clear vision at distant and intermediate vision with the correction of toric IOL. So this also adds to our answer that we really need to tackle these problems, the astigmatism and presbyopia. We are witnessing a revolution. It's not yet finished, and the refinement and improvements will go on. Hopefully in the next few years, we will see something to improve, or even our current technology that will provide our patients with a better even results. This is one of the very early first trifocal lenses introduced in the market. That is the Faisal from Fine Vision. It was introduced in 2010. So the technology of trifocal, we're almost 10 years now. This is the Atelisa from Zeiss, were really very successful, following the trifocal lenses from Faisal, and there is a wide marketing field during that time. Following that, many companies came up with the idea of a trifocal and discovered that this technology really provided very optimum results for the patients with a minimal photic phenomena and side effects. So this is the Liberty from Medicontour lenses, and Panoptics from Alcons, and many even other companies has the same idea of providing this technology. This is the RayOne preloaded, and which is only fully preloaded trifocal lenses from Rayner. I enjoyed using these type of lenses for almost 2 years now. I didn't have more than 50 of IOLs implanted. It is limited somehow experience, but according to these 50 cases, I really enjoyed it, and it has very optimum results with almost zero explantation. And this is one of the also other technology that is the extended depth of focus from Symphony, has somehow limited even market nowadays. So we presented some of the current available famous trifocal lenses, or even multifocal lenses that has a market nowadays. So why the patient sometimes really unsatisfied, and these are some of the pitfalls of unsatisfied patients. So some patients are really bothered with the photic phenomena. Some other patients are really bothered by the residual ametropia. They have some residual hyperopia, myopia, or even astigmatism will limit the results of the surgery. The development of PCO also is one of the dissatisfaction factor of the patients. IOL decentration, if it is present, inadequate pupil, dry eye, or even large angle kappa, and we'll go through each of them in the coming few slides. The photic phenomena is really present in many patients. Some studies report almost 75%. In our study, even we published a few years ago, almost 80% of our patients report some sort of glare and halos. But the good news that less than 10% will be reporting disabling or really bothering glare and halos. About the residual myopia, we know the multifocal lens especially is more sensitive to residual refractive error, and it may occur from inaccuracy of biometric analysis, inadequate selection of IOL power, limitation of calculation formulas, or even errors in the IOL positioning, and the treatment somehow is PRK or femtolasic if it is really significant ametropia. If you have an inadequate pupil size, you need to tackle that with the patients before, and even exclude these patients from doing the premium IOLs. Patients with very small postoperative pupils might complain of poor near vision, where very large postoperative pupils might complain of increased photic phenomena. The PCO is really common in some specific trifocal lenses, and especially the atelesa from Zeiss. Some of the studies shows even more than 30% of these cases they had significant posterior capsular ossification, and the ENG capsulotomy will be the solution of these PCOs, and should be done more than 6 months post-operative. Regarding the patient selection and counseling, and this is very, very crucial, I think the ideal patient should be very much motivated to achieve the spectacle independence. He should understand the limitation of premium IOLs and should have a realistic expectation. So if you want to gather the important things, please avoid those patients who have very high expectations, severe exfoliation, high cylinder. If you have high cylinder, you can refer to the toric type of trifocal lenses. Try not to implant premium IOLs and corneal opacities, or even post-refractive surgery, especially the RKs. Even a large angle capa should be avoided for the premium IOLs, especially trifocal lenses. Corneal haze, as I mentioned, large pupil more than 7 or 6.5 and 7, you should avoid the trifocal lenses in these cases. And dry eye. Dry eye also is one of the really important things to assess preoperatively, to know if these patients might really does not like, the trifocal lenses. This is one of the studies we published before with the atelesa. We used the visual function index to assess the reading ability, the intermediate abilities, as well as the far vision for these patients. Really the results, and this does not go with the only Rayner lenses. We used at most the atelesa Zeiss, and we have very satisfying results. We have almost zero explantation. Satisfaction were very high, and around 90% would recommend these type of lenses to their relatives. Photic phenomena were reported in 75%, generally non-disturbing, especially for, or I'm sorry, except for those having night vision dependence like drivers. Those might not like these type of lenses. So in conclusion, the implantation of trifocal IOLs after cataract surgery might provide very effective and efficient visual restoration with the association of minimal level of photic phenomena, a positive impact on the performance of vision-related daily activities, and high level of post-operative satisfaction were noted in our experience and studies. Thank you so much.
Thank you very much, Dr. Khaled. We have a couple of questions already coming in, and also I believe a couple of polls you would like to launch, so we can find out a little bit about our audience. So if you can just stop your screen sharing, and I will launch the first poll. Yeah. So we're asking how often surgeons in the audience actually offer premium IOLs to their patients. And while we're waiting for the poll result to come in, maybe I can ask you, do you offer premium IOLs to the majority of your patients, or is it a minority?
So very good question, and I face that almost in my daily practice. Those patients were coming for refractive surgery, and they are above 50, and they are very well educated nowadays in our society. If they are really suitable for premium IOLs, I immediately offer the premium IOLs for them. Why? Because I really convinced that Premium has optimized my practice, and especially in our society. It really helped a lot of patients. I remember just a few years ago, 6 or 7 years ago, the multifocal lenses were very rarely in my list. Nowadays, the Premium is accounting more than 20% of my daily cataract list because of increasing the popularity of these type of lenses.
Interesting. Okay. From the audience, there are quite a number who offer either not at all or less than 10% of the time, but also over 25% who offer premium lenses over 50% of the time. But there's quite a spread. One of the questions was related, which you've touched on, is to do with how educated the patients are now and how many actually come to you asking for trifocals in the first place.
Yes, very good question. The patients are is really very educated, and they know about the trifocal lens, and they tell, please, if the trifocal lens is suitable for me, please provide that for me. And they really enjoyed the vision with the trifocal lens. Most of these they are independent of the glasses most of the time, and it gave very good reputation in the last few years. But I will mention that the multifocal lenses before had really ups and down reputation, and we have even medical legal cases. I mean, where we're asked to assist some of the multifocal old versions, and there are so many explantation. Those of old surgeons know that the old version of multifocal lenses are really giving the dark side of that type of lenses. Nowadays, the things are really different. The technology provided us with much better optimum results.
Excellent. And another question here from one of the attendees was, do the majority, or what kind of percentage of your patients have some level of cataract, and how many would be more of a clear lens?
Great question. It depends, actually. I offer both, even for the clear lens extraction, but you know, those of having clear lens extraction should have some sort of the dysfunction, accommodative dysfunction, and their age should be more than 45 or so. I don't usually like to do these for young patients unless very, very exceptional cases. The dose of having cataract with the premium IOLs are the maybe 60% or 70% of my premium lenses, where the clear lens extraction almost 40% of my practice.
Okay, so yes, so it's quite high. And what are another question coming in from an attendee was, what is your favored biometry method and calculation formula? Do you have something that you use every time, or?
Yeah, it depends on the axial length and refractive status. Like SRKT will provide very optimum IOL calculation of most of my patients, unless the patient's really high hyperope or hyperope, we will use Hofer Q. And some very mild, very regular cornea post-refractive surgery, I might use Hagias, IOL to provide optimum IOL expectation for the power. And these are the Hagias for post-refractive, the Hofer for hyperopes, and the SRKT for most of the emmetrope or myope patients.
Excellent. Our recommendation with RayOne Trifocal is to aim for 0 for emmetropia. Is that your experience with the lens?
For the minus 0.2 to 3, actually.
Okay.
Minus 0.25 or 0.3 will be much better for the results. I don't aim for emmetropia 0.
Maybe I have a question.
Great.
Yeah. What is your limit of corneal astigmatism when you are using trifocal IOLs?
-1 is my limiting astigmatism. Even if you have more than 1.2 or up to 1.5, it is a controversial, but more than 1.5, you should use a toric type of lenses. If you have a toric +1 and above, that's even better, but sometimes it's really forgiving, and I might even do regular trifocal lenses with the 1 diopter of astigmatism. And the difference is not really much. The patient tolerates somehow the 0.75 of astigmatism, even up to one diopter of astigmatism.
It's my same idea.
According to my experience, and even my colleagues have the same thoughts and background.
Yeah.
Excellent. Well, the good news is from the next poll is that 100% of the attendees would consider premium IOLs in future practice. I think yes, the argument there is definitely one. And then the decision is really which premium IOLs you choose to use. And as you touched on, there is a very wide range. So there are more questions coming in, but for now I will move on to my presentation, and we will have some further discussion a little bit later on, if that's okay. So we'll just share my screen. Hopefully you can now see it. So I'm going to talk for the next 10 minutes or so about the RayOne Trifocal in more detail and how it compares with some of the very well-known competitors. And I will also touch on patient-reported outcomes and how you can collect those very easily remotely with our very own RayPRO app. The RayOne Trifocal is part of a family of RayOne preloaded lenses. So whichever kind of lens you're using from Rayner, it's exactly the same injection system. It's extremely easy to use. Here's a demonstration of just how easy. It's viscoelastic into the port, whichever is your favored viscoelastic, and then close the cartridge. So it's very convenient and does save some time, but also it's safer for the patient. The chance of a damaged lens having to be removed from the eye is massively reduced. You can see here that Mr. Barson from the UK prefers to do a wound-assisted technique with a very small incision of less than 2 millimeters, but that is quite easy with the single-handed plunger, allowing him to use his second instrument to stabilize the eye. And you can see the lens emerges very smoothly and in a controlled manner. And it's very simple to tuck in the trailing haptic if necessary. And then it just remains to, of course, remove all the viscoelastic from in front and behind the lens. So the learning curve for using the lens is virtually non-existent. Everything about using the trifocals is really to do with, as we already heard, the patient selection. It's not anything new to learn in terms of implanting the lens. The Rayner platform is very well known and very well proven. We have excellent double C-loop haptics, aberration neutral aspheric optics, fully preloaded across the whole power range in the same size injector tip. So you do not have to change for very high diopters. There's no glistenings at all with our material, and we have extremely low PCO, even with the trifocal lens where you would expect more patients to notice a small amount of PCO compared to a monofocal. And of course that is true, but it's still an extremely low PCO rate with our lenses. It's very important to note, and should give you some confidence with the lens, that we've been using the same material and basic lens design since 2006 in over 8 million lenses. The anti-vaulting haptics are extremely important in a premium lens because they provide superb centration, but also superb rotational stability. And there's been a number of peer-reviewed clinical papers proving this. Also, when the capsule contracts, the haptics allow for the absorption of the force without making the optic move backwards or forwards, the vaulting effect which can happen with more rigid plate haptic design lenses particularly. So, which obviously causes a change in refraction, sometimes many months post-op, and of course we want to avoid that. Moving on to the optic, there are some obvious differences in the lenses. These are the four, I would say the four most well-known worldwide trifocal lenses. Of course, the Zeiss and Physiol lenses were the first two on the market, the first two trifocals. The obvious thing to note is that they have rings all the way to the outside of the optic. The two more recent additions do not have rings on the outside of the optic. So why do we have just 16 rings surrounded by an outer distance monofocal zone? Well, it's of course to guard against problems reported from patients with larger pupils. We know that the patients with naturally large pupils, or when they are driving at night, for instance, when their pupils become larger, are the most likely times when they will complain about glare and halo. So when it's a normal pupil size, we can see the light split is quite traditional, you could say, for a trifocal with, of course, distance is dominant, the most important, just over 50%, and the rest shared between intermediate and near. But if it's a large pupil, the lens becomes much more distance dominant to guard against the occasional complaints of patients from driving at night. And where driving at night used to be something with the old multifocals, as Dr. Khaled touched on, which was really very problematic most of the time, it's now the other way around. It's problematic very rarely, but of course it needs to be discussed with patients still. There are still, of course, dysphotopsias with every diffractive lens, but they are much reduced. And things like this design with no rings on the outside really help that. You can also see this figure, we only lose 11% of the light. So every diffractive lens, every multifocal lens scatters and loses some light and is not able to use that light for the focal points. This scattered light is what causes a lot of the dysphotopsia issues, and it also reduces the contrast available to the patient. You can see here the comparison between 14 and 11% light loss may sound quite a small difference. It's actually a 21% reduction in the light loss. To illustrate, you can imagine a 14-story building, an 11-story building. The difference in height is 21%. It's not 3% difference. It's a large difference in the amount of light that's being scattered, which can cause visual symptoms. If the patient has large pupils, and then they are accessing our outer monofocal zone, which does not really lose any light, then this effect is actually increased, and our light loss will go into single figures. Whereas the Zeiss and Physiol lenses with rings all the way to the outside do not have this feature. Here we can compare the particular amount of light for each focal point between the lenses. It's a little bit hard to see here, so I will show you in a graph form. There are some obvious differences, particularly between the Physiol, Zeiss, and Rayner and Alcon lenses. Physiol has much less light for intermediate. So the dotted line, it starts with less light, and then as the pupil gets larger, because the steps on the Physiol lens get smaller, it becomes more and more distance dominant, even at normal pupil sizes. So whilst, of course, it's a very good lens and has been the class leader for many years, if there are any complaints on this lens, they can be to do with the intermediate vision more often. With the Zeiss lens, it's quite a different story because it has full-size bifocal rings all the way to the outside of the lens. The trifocal, the intermediate, drops off on the outer portion, but it's still a bifocal diffractive lens with full-size rings all the way to the edge of the lens, which is more similar to the older designs of lens. There is less light being scattered by this lens, but still you can expect that with large pupils, there is some more likelihood of halo and glare being mentioned by patients. The two most recent lenses on the market look a little bit similar on this graph because they both have an outer distance zone from 4.5 millimeters. Comparison of the MTF from the Rayner and Physiol lenses on the optical bench really confirms what we just saw, that yes, there is a slight advantage on near for Physiol, but a much larger advantage on intermediate for the Rayner lens. And it's more of an even split between the two focal points. You can also see a distance advantage for the Rayner lens. Most obviously, this will be down to the less light being lost and scattered. So then we can look at the various near and intermediate additions of the lenses. 3 of the lenses are very similar. In fact, Rayner and Faisal have exactly the same near and intermediate distances, and Zeiss is very, very similar. And I think that these are quite logical distances, to be honest, and that's why they are so similar with those 3 lenses. The Alcon lens is quite different. It has an intermediate add, which is 2/3 of the power of the near instead of half. Logically, this seems to make a little bit less sense. It's not in the middle between the distance and the near. And whilst patients certainly tolerate this lens very well on the whole, there are reasons why the Alcon needed to make it in this way, and we can look at that now. So going back to this comparison, it's not just the amount of rings, it's actually the shape of the rings. The diffractive profiles are very different between the lenses. So although for the patient and the surgeon, often you can say that the trifocals give quite similar results to each other, there are definitely differences, and the way they work is very, very different. The principles behind the lenses are completely different. To explain a little more, this is an image from a physics textbook of the theory of diffraction. So you have the 0 order of light which is traveling straight through an aperture which is not diffracted, surrounded on either side by parallel orders of diffraction. But you can see that they are becoming slightly more faint and spread. This is chromatic aberration because the different colors light travels at different speeds. Each further order of diffraction is a little bit more spread than the one before. So when this is applied to IOLs, the early bifocal diffractive IOLs use an asymmetric pattern, and they were trying to access just the +1 order, the first order, to use for their near vision, and they still use 0 for distance. But these lenses lost over 20% of the light that was entering the eye. Much was scattered into this further out zone, but it was not useful for vision. The first trifocal pattern, which is shared by Faisal and Zeiss, and they have an agreement between them, and they share this same patent, and they both therefore lose around 14% of the light. This involves combining 2 asymmetric patterns. The only difference is that one lens is apodized, and the steps become smaller towards the outside, and one is not. One pattern is producing distance and intermediate, and one pattern is producing distance and near, now using the +2 order of diffraction for near. Now, these orders of diffraction are nothing to do with the actual power of the add. You can select that with the design of the lens. It's a completely separate issue. So then we move on to the Alcon design. This is the second trifocal patent, and they had to do something, of course, therefore different to avoid the first patent, and they came up with this design using the second and third orders for intermediate and near, and this is why the intermediate is 2/3 the power of the near and not half. They are also using slightly further out orders of diffraction, and there are theoretical optical reasons that this might be slightly less good for the clarity of vision. Of course, the differences are not going to be huge, and you will not notice from 1 or 2 patients, but if you do a large comparison study, maybe these things can be apparent. The light loss was reduced though. They did very well in reducing the light loss down to 12%. And the most recent trifocal patent, there are only 3 trifocal patents. Other lenses which are called trifocal in their marketing are potentially not a true diffractive trifocal, but use other methods to achieve 3 focal points. So the third trifocal patent for Rayner, with even lower light loss, involves combining a symmetrical and an asymmetrical pattern. The symmetrical part allows us to do something very different and access the -1 order of diffraction, as well as the 0 and the +1. So we actually use the -1 for distance, 0 for intermediate, +1 for near. This means that we are using the 3 sharpest, clearest, least chromatically aberrated orders for the 3 focal points. It's not the kind of thing you're going to be discussing with your patients necessarily, but it's very interesting to note that the technology behind these lenses is really quite different. We have a toric version of the trifocal, and we were just discussing where trifocals may be required. It's using exactly the same technology, of course, but we have something quite unusual. We have a very low cylinder option, a 0.75 cylinder option. We've deliberately made the price differential not too great, and we have this option. And the idea is that, of course, you can get good results as discussed with 0.75 or 1 diopter of residual cylinder, but even better results can be possible with even less residual cylinder, and you will have fewer of the unusual, less happy patients if you reduce the cylinder even further. So we know we need to treat these patients with higher cylinders with a toric version, but we can also look at these patients with around 1 or 0.75 diopters of pre-op cylinder and potentially correct that as well with the toric lens. These are calculated very easily, either on your own calculation device or on our easy-to-use online calculator, where you can calculate any Rayner IOL, including the Sulcoflex IOL, which we'll hear about a bit later. So summarizing some of these points, we have slightly lower light loss, aberration neutral, we're not aberration correcting. This means that we are less sensitive to small amounts of decentration. And it means that as we are not measuring every cornea before surgery, you can be quite relaxed that you are using a lens which will not be a bad choice for any cornea. I think our haptic design is a real advantage over the competitor lenses, as is the fact that it's fully preloaded for both convenience and patient safety. There has been an excellent comparative paper, peer-reviewed paper against the Faisal fine vision lens, published last year in Journal of Refractive Surgery. They found, of course, both lenses are very good lenses with very similar results with very happy patients. However, they did find statistically significant better refractive accuracy with the RayOne Trifocal, with all eyes within 0.5 diopter of attempted target. And they also asked some very interesting questions using the Macalinden Quality of Vision questionnaire, asking patients to grade the level of these various visual symptoms on a scale from 0 to 3. What they found when they asked the patients how much these different symptoms bothered them was that in general they were, happy with both lenses. These scores were quite low for almost all of the questions. However, the glare stood out a little bit, and the difference between the lenses does stand out as well. And glare is known to be, this was a 3-month follow-up, and glare is known to be the symptom which patients do not adapt to in the same way. They do not get used to it in the same way as halos and other symptoms. And so this advantage in terms of glare, which is quite large on a scale of only 0 to 3, is really quite interesting and significant, I think. Before I go, I would just quickly touch on RayPRO, which is a method of collecting information from your patients with Rayner IOLs. It's completely free to Rayner IOL users. It's a desktop and mobile app. It's very, very quick to register your patients on there, and they will then receive 5 short emailed questionnaires over the next 3 years, asking them various questions. And this will give you invaluable information. You can register with a member of your team. You can set up an account for your nurse or person in your clinic. The patients will receive questionnaires asking them about their satisfaction with the surgeon, the hospital, the outcome, spectacle independence, dysphotopsias, target vision achieved, and if they had to have any additional procedures. So this is a very easy way of finding out things like your YAG rate, laser touch-up rate, and of course, how many patients, if you're using a trifocal, do not need to wear glasses. And once you've registered them, then they go away. You don't have to do anything else. You receive the results onto your mobile phone or onto your laptop. It's completely anonymous, so the patients will not, they will be able to fill it in. You will not see their names, but you will see the overall trends from your patients. Rayner will also see the overall trends, and this will help us develop future lenses, help us with our R&D. if anybody wants to know more about RayPRO or any of the other Rayner products, our website is excellent and very informative. You can access clinical papers and you look at videos, rayner.com. And we have a Rayner IOL YouTube site where you can see many videos, tutorials, previous webinars, and this webinar as well will be on there in the coming week. So that's all for me, and I will now hand over to Professor Amon, and I will take my questions a little bit later after Professor Amon. Over to you, Professor.
I just want to open my presentation. I'm going to talk about Sulcoflex, which is a totally new concept in surgery. This lens exists since quite a long time, since 14 years. And I want to give you a glimpse on the development of this lens. And finally, I want to talk about the new trifocal Sulcoflex lens and its application. Starting with the history. It is important as lenses are put into the sulcus that they are hydrophilic, because hydrophilic material has a much better UV biocompatibility as compared to hydrophobic lenses or silicone lenses, which are almost not on the market anymore. So we could show almost 15 years ago that hydrophilic material is superb to hydrophobic material. So it's important that you have a hydrophilic material for an add-on lens, which is put into the sulcus. Right now, there exist 3 different types of add-on lenses. There is the crystal lens, the Rayner Sulcoflex lens, and the first Q lens. All of these lenses are hydrophilic. The idea of creating an add-on lens specially designed for that purpose was long time ago. I started this idea in cooperation with Rayner at 2000, so it's almost 20 years ago now. Then it took 4 years to develop that lens, and in 2007, I implanted the first aspheric monofocal Sulcoflex lens in order to correct some ametropic surprises, biometrical surprises, or to put the lens in if there was a single lens was not available for correcting the patient's refraction. So later on, we developed toric lenses and multifocal lenses, at that time refractive bifocal lenses. But very new is now the trifocal lens, which was first implanted in 2018. We had some cadaverized studies, and we could show that that lens is well centered and has an appropriate sulcus fixation in the cadaver eye. It was from Miyake viewing, so we could see that. And one important thing is, and I want to stress that, the optical bench studies. If you put 2 lenses into the eye, a lot of people think that there are more surfaces within the eye, and because of that, there's more glare or other problems with light loss. That's not true. It could be shown on the optical bench that they are similar, that the optical quality is similar to a single lens, and the additional light loss is less than 1%. So you have almost the same optical quality if you put 2 lenses within the eye or if you have a single lens within the eye. I think that's very important for the argument using a DUET procedure, an add-on lens. We did a study 13 years ago with 200 eyes using this Sulcoflex lens, and we could show that it is a safe lens. The platform is still the same. It's a safe lens. There was no iris trauma, no pigment dispersion with that design, and no interlenticular opacification. And which is important, there was also no contact between the iris and the anterior lens surface. You can see that on the UBM here on that picture. And there also was no contact in the central zone between the two lenses, as the posterior surface of the Sulcoflex lens is concave. So there's a space in between, and because of that, there is no distortion of the optical image in the center. We also performed the centration study with comparing the bag lens to the Sulcos lens in the same eye. And we could show that the centration in the Sulcos lens is superior to the centration of the bag lens. There was a better centration in the sulcus. And additionally, this centration was stable. There was no movement of the centration. It is easy to understand because there is no capsular contraction or something like that. And because of that, the Sulcos lens was better centered and more stable in the eye as compared to the lens in the same eye in the bag. There are specific indications for add-on lenses. For instance, children, they have a myopic shift because of the growth of the eye. And in that case, you see the video above, it is a 2-year-old boy with a unilateral cataract. I did a cataract and put an add-on lens in order to make the patient ametropic. And 5 years later, the eye grew and he became myopic. So I did an exchange, and it is the same eye you see below, where I did an exchange of the lens. So with that lens, it was also possible to titrate the refraction, to adjust the refraction to the patient's eye. Also in silicone oil or some other situations of the eye where you have a change, a dynamic change of the refraction, it might be useful to use an add-on lens for that purpose. So in conclusion, after 12 years of follow-up, supplementary IOLs are effective for the secondary enhancement of the surgical result and for the primary DUET implantation. I want to show you now the last step we made, and this is the trifocal lens. You heard a lot about the optical quality and the optical design of the RayOne Trifocal. It's totally the same on the Sulcoflex lens. So the optic is the same. It has 16 rings and everything the same. The only difference is that it is an add-on lens with the same platform as we heard already. You have heard that already about the comparison of the 4 different trifocal lenses. We just compared the Symphony and the Atelisa 3 to the RayOne lens and could show that it is absolutely similar in the results. Coming to the surgery, if I do a secondary implantation, so if I want to correct an ametropia in a pseudophakic patient, it is straightforward. If you have a surprise which is hyperopic, you take the spherical equivalent and you multiply it by 1.5. You don't need biometry or something else. You just have to multiply the spherical equivalent. If the patient is myopic, you just multiply it by 1.2. And that works in a range between plus and minus 7 diopters. You also may use the ray trace calculation, but this is a very simple calculation system I use. If I do the DUET procedure, that means I do a cataract surgery, put a monofocal lens in the bag, and then on top a trifocal lens. I use my standard formula, put the monofocal lens into the bag and aim for 0, and put the Sulcoflex lens with distance correction of 0 on top. That's my straightforward routine biometry, and I don't need to change it. I think it works very nicely. Here you see a DUET procedure, 2.4 millimeter incision. Then you do the cataract surgery. You implant the first lens into the bag. After implantation of the bag lens, it's important to remove the viscoelastic from behind the lens in order to have the clearance of viscoelastic from the bag. Then I lift the iris and prepare the sulcus. And finally, here you see that Sulcoflex lens. It's a very soft and thin lens with a 14 millimeter haptic diameter and 6.5 millimeter optic diameter. It is here in a Medicell injector. It's very easy to fold that lens. It's just important that you don't construct the closing wings, and you have here a plunger, and you press the lens to the nozzle, and here you will see the haptic opens very controlled. The leading haptic, I try to bring it under the iris and above of the rexis, and then the trailing haptic is following. The same thing can be done secondarily. So if you have a patient who has already a monofocal lens in the bag, you may enhance the situation by implanting a Sulcoflex lens in the sulcus. Here you see that procedure. It's the same procedure, it's straightforward. You open the eye, put viscoelastic in, and then you inject the lens on top. If you have an ametropia in that situation, you also can correct that, and there are quarter steps of diopters in the very small range between 0 and 1 diopter. So you also can really exactly correct the monofocal lens by enhancing it with a trifocal add-on lens, including correction of the ametropia. It's also important that this procedure is reversible. So you may easily remove that lens in case of photodysphotopsia, or later on if there is development of some macular degeneration or glaucoma. If you need some change of the optics, you easily may explant that lens, and I will show you that right now. It is straightforward. It's a 2.4 millimeter incision. You just grasp, I bring out the haptic first, and then I grasp the optic at its edge and just pull the lens out. You don't need to cut it, to fold it in the eye. You just bring it out. It is very thin and it folds along the corneal incision. So it's straightforward. So in my opinion, it's a reversible procedure. The results with DUET implantation, we did the first implantation in the world in July 2018, and we could show that there was no significant difference as compared to the RayOne Trifocal. So we have the same results with the reversibility in DUET procedures. With secondary enhancement, we also have done cases for secondary enhancement, and even with these patients, I have here a patient now, but I will skip that because of the time, you can create very nice and good results. The only one thing you have to take into consideration is that if you have a monofocal pseudophakic patient with a good far distance, you have to tell him that he will have some glare phenomena and halos he's maybe not be expecting before, because he has not seen that in a monofocal lens. But if he knows that, usually it is a very straightforward procedure, and the patients are happy if they don't want to wear spectacles for near. So in conclusion, there are excellent visual acuity results across all distances. They're very similar to the results of a mono lens system put into the bag, but, and that's the important message, supplementary IOLs offer an adaptive reversible solution. So you can and you may step backwards. This is a big advantage as compared to a multifocal lens put into the bag. We all know that it might become difficult if you have to exchange that lens, especially late after surgery. There's the option of fine-tuning. We have quarter steps. I mentioned that already. And I also said it's a reversible implantation option. Early explantation because of photopic phenomenon, or fine-tuning if you don't have a biometrical exact result. And late explantation, we never know what happens into decades after surgery if the patient develops AMD, diabetic macular edema, or whatsoever, and we can step back anytime later on. So the main indications today are in phakic patients, multifocal DUET implantation, and in pseudophakic patients, multifocal enhancement or the correction of a biometrical surprise. I think it is a safe procedure which is reversible. Thank you.
Thank you very much, Professor Amon. We already have some questions for you. You touched on it there, but the question about what the primary lens is made of, or what material, what type of lens, whether this matters for Sulcoflex.
It does not matter. When we did over 300 in all right now cases, and we put that on top of a silicone lens, we put that on top of a hydrophobic lens or a hydrophilic lens. There is no interaction between the lens materials and the lenses themselves. So there is no problem using any lens in the bag. You don't have to consider it, really.
Excellent. Sorry, we've just lost your video link for a second there.
Okay, I will open it. I will open it.
Thank you.
Okay.
One question from me when I'm talking about DUET, I normally say that the standard is to do the procedure simultaneously, because there is no extra risk of missing your target with DUET than with normal cataract surgery. So if you expect a good refractive outcome, to do it simultaneously seems to make sense. Do you have a group of patients where you would prefer to do it separately? Maybe if it's a very long or very short eye, or if they had laser surgery in the past and the biometry is more difficult to predict?
I would not, no. Even if there is a higher risk of the refractive surprise, I would straightforward implant the lens combined in a DUET procedure, because if there is a biometrical problem, I just need to exchange the lens, which is not difficult, and that's very rare. But if I don't do it, if I do just the bag implantation first and plan to do the second lens, let's say 1 week later, I have a second surgery in 100% of the cases. So I want to have the second surgery only in 1% of the cases, maybe, or less. And if that is, it's not more difficult than just implanting the lens. You just explant it and exchange it. So I never would do it in a two-step way. I always would do it in a DUET procedure.
Interesting. Dr. Khaled, do you have any questions at all for Professor Amon?
Yes, I was really interested in when I heard about it 2 years ago, and I wonder the results, and I really admire your presentation. It looks like very promising and might really help a lot of ametropic patients post monofocal or even trifocal lenses that we can handle these patients with. Do you have any comparison if you treat ametropic patients with corneal refractive surgery? Do you have an experience with that compared with the quality of vision you can provide with these type of lenses? Because one of the even options for the ametropic patients to do corneal refractive surgery somehow for the astigmatism as well as the residual myopia or hyperopia even. Do you have any comparison if you do both? Or
I have not compared it in a study, and as I'm not a corneal refractive surgeon, I always, if I have an ametropic surprise, use the add-on lens. But I think in comparison, it should be very similar. I don't expect any optical difference between the two things. The only one thing is refractive corneal surgery is irreversible, but add-on lenses are reversible. That's the advantage, I think, even in that situation.
Yeah, I'd just like to add there, I've seen some interesting presentations from refractive surgeons who, even though they have the laser in their clinic, their default method of correction is actually the Sulcoflex, because they find it is better tolerated by the patients in terms of just the patient satisfaction and the patient journey, because it's a similar procedure. It's very short. There's not pain afterwards. There's not a recovery period.
One advantage is if you do LASIK, you have to wait, let's say, a few weeks until it is tight. With that add-on lenses, you can do it on the next day. Yeah, you don't have to wait. You use the same incision and correct it on the next day.
Yes, exactly. We have a couple more questions also for Dr. Khaled that have come in since earlier, and there are still some coming in for Professor Amon, so we will just mix it around. How did you find the PCO rate is one of the questions for the Rayner Trifocal. I mentioned it was low, but maybe I would say that, so we will ask you.
I was trying to answer some of them in the chat bar. My experience with the Rayner is not too much. I mean, I just finished 50 IOLs implanted in the patients, and I never did any capsulotomy for these patients. So this indicates the low rate, very low rate, because of the configuration of the lens and the loop of the haptic loop, and it's very, very much low, and compared with some other types, and specifically the trifocal ateles Zeiss, it's really high. Trifocal lenses, PCO, and the capsulotomy reached up to 30 or 35% of my patients needed.
With the Zeiss lens, okay.
Needed capsulotomy, 6 months or more post-operatively. The Rayner cases, 2 years ago I started, I never did any case of capsulotomy for them. And so I hope it's really very low rate of PCO.
I think they have a very low rate. You're absolutely right. Even though they are hydrophilic material, which should have a little bit higher rate, but because of the special haptic edge design, optic edge design, the sharp edge design, I think you're absolutely right. They have a very low rate of PCO.
We have a couple of questions which are quite common, I think, regarding Sulcoflex, to do with patients with higher pressures or with shallow anterior chambers, and your kind of cutoffs or your guidelines for these patients.
I don't have a cutoff with the anterior chamber depth or something. I have implanted that lens into children which have a total length of 40 millimeter in some cases. And the lens is very thin and there's space enough in the posterior chamber. So as long as you don't put it in upside down, you shouldn't have any problem with anterior chamber depth or something. So for me, there is no limit. If the eye is very short, children, for instance, or very hyperopic eyes, I would do a peripheral iridectomy, but only in these cases, not routinely.
Okay, great. And if the patient has a raised IOP at all, then this would be something that you would...
If he has a glaucoma, I wouldn't implant that lens, I would say, yeah. But I think the cause of glaucoma is not the lens. I never had a patient who developed glaucoma, secondary glaucoma, after implantation of an add-on lens.
Yes, and we have, as I think you mentioned, over 45,000 implanted over the last 13 years. Compared to the other add-on lenses which you mentioned, a lot more have been implanted of our design, and over a lot longer period of time. So we have had a long time to find out any issues, and fortunately there have been very few. We have a question for both of you regarding explantation of either the RayOne Trifocal or the Sulcoflex Trifocal. So Dr. Khaled, maybe you can go first.
Actually, I have a video explanting trifocal lenses. I was putting in my presentation, but I was seeing the slides and I take it out because I want to see even the dark side of these type of lenses. I explained the two cases. One of them, they have very much decentration because of compromised bag, and that was the reason for explantation. Patient did not tolerate the lens, and the other type of trifocal lens even was referred. The patient was really ametrope with the residual of plus 2 diopter, and he really wants to get rid of the lens, and we put up a monofocal lens for that patient. So total of 2 explantation, but these patients are referred to us from outside, and there was obvious reason why those patients are really unsatisfied with these type of lenses. None of them are Rayner.
I see. And none of them are Rayner, but also they're not your patients. They're ones who have come with, they've missed target or something like that. Maybe in the future, the Sulcoflex lens for this patient will be a nice method of correction. And for you, Professor Amon, have you had to remove any Sulcoflex Trifocal or any other Sulcoflexes? Or
implanted Sulcoflex Trifocal because of in children because of exchange. This was
expected. Yes.
I also explanted one because of a photopic phenomenon. I had one to explant, but it was straightforward, and the patient knew that I would explant it if he wouldn't accept it. And after waiting for 3 months, I explanted it. It was very easy. Just want to add that I explanted quite a few trifocal lenses from the bag, and especially the Zeiss lens, the plate lens, is not so easy to explant. It is very ingrown if you wait for a too long time, and it was not so straightforward.
Okay, Thank you. And I guess you feel a little bit more relaxed about the possibility of explantation with Sulcoflex than with this type of lens then. So I'm just going to check if there's any more questions just coming in before we wrap up. We are just going slightly over time. I think most of these questions have already probably been covered. Is there anything else you would like to ask each other before we wrap up the session?
There is one question about the implantation of Sulcoflex patients with high IOP. Did you touch up this question, Dr. Amon?
Yeah, I mentioned it. I would say if there is a patient with glaucoma, with high IOP, I wouldn't implant an add-on lens. I think this is one of, if he has glaucoma, it's one of a contraindication, yes?
So,
yes.
Is there any risk of pigment dispersion syndrome or even higher IOP in this type?
I never had a pigment dispersion syndrome combined with eye pressure rise, yeah? So I never had a secondary glaucoma because of pigment dispersion. In some rare cases, you see some faint pigment granules on the anterior surface of the lens. If you call that pigment dispersion, in some cases you realize that, you see that. But I never had a secondary glaucoma, a severe pigment dispersion syndrome, no.
Thank you.
Dr. Khaled, there's a question regarding using trifocals with patients who had laser correction in the past. Is this something that you are very reluctant about, or you do you do this?
Yes, that was really controversial at the early of my experience. Lately, I might consider these type of lenses, and whenever I have very regular cornea and the cornea topography, and they have very minimal even cylinder, and the case are really within normal, like in 39 up to 43 or 44, not more than that, not the very high case or very low case that will even add to the compromised quality of vision might be even with these type of lenses. So with a special situation, yes, I do that, and I really am very satisfied with the results. So far, they do very well, even with the post PRK or even femto-LASIK or LASIK cases, not the R case. Obviously, whenever you have very irregular cornea, these type of lenses with ocular surface disease might not really tolerable, and I don't recommend for them. But a regular good case of post-refractive, yes, they do well.
Excellent. Okay, well, we've just launched just got our final poll results, which shows that the majority of the people attending today, the vast majority, using trifocal IOLs as opposed to the other options. And I think that probably mirrors what we find out in the world today, that this is currently the best solution. It's not yet perfect. We do not have the accommodating lens which works like the natural lens. We know this, but we have made some big improvements, and I'm glad that you're both enjoying the Rayner technology. Thank you both for joining us. Thank you to our attendees in Saudi Arabia and the Gulf region. And this video will be available in full on our YouTube channel in the next week. And if you want any further information, please visit our website or the YouTube channel. Thank you very much.
Thank you.
Thank you.
Thanks.
Doctor, goodbye. Thank you.
Goodbye.
Pleasure meeting you. Bye.